So good morning, everyone. Thank you so much for being here. This is around our sixth LGBTQ plus health program grand rounds. I'm so excited to be hosting a session focused on our education initiatives right now. We have Dr. Mike Gisondi and Deila Baumgartner here to talk about our Teaching LGBTQ Health materials, which is one of the only faculty-focused educational materials on LGBTQ healthcare. And huge shout out to both of them for leading this effort and creating one of a kind, and very excited we have a new content that we're working on to expand these in collaboration with the EdTech team. So really excited for where this is going to go and excited to share this with everyone, because whenever I communicate with most people around the enterprise, folks are unaware of this great resource that we have. And they're going to tell you much more about it. So I won't go into those details, but I will introduce both of them. So Dr. Mike Gisondi is the inaugural Vice Chair of Education in the Department of Emergency Medicine and Assistant Dean for Academic Advising at Stanford School of Medicine. He's the principal and founder of the Precision Education and Assessment Research Lab, the PEARL, co-director of the Scholarly Concentration in Medical Education, and a distinguished member of the Stanford Medicine Teaching and Mentoring Academy. He previously served on the board of directors for the Council of Residency Directors in Emergency Medicine, and earlier in his career, he served as director of the Feinberg Academy of Medical Educators at Northwestern University Feinberg School of Medicine. So thank you so much, Dr. Gisondi. And I have to say, it's been a pleasure working with Dr. Gisondi on the expansion of teaching LGBTQ health materials. We're so lucky to have you here and collaborate. And Deila Baumgartner is an instructional designer, graphic designer, and video editor for the Stanford Medicine Educational Technology team. She has had the privilege of working with the EdTech team since 2016. Her work has been primarily focused on online and hybrid educational activities and curriculum for UME, GME, and CME. She's the lead instructional designer for the Teaching LGBTQ plus Health course. Prior to working at Stanford, she taught film and broadcast journalism at the Presentation High School and worked as instructional designer for UCSF's Clinical and Translational Science Institute and Apple. So thank you so much as well. And I'm excited to turn it over to both of you to present the session today.
Well, thanks so much, Blaze, and thanks to Peyton for arranging this, and to the LGBTQ plus program for having us. This is really an honor to be one of the grand round speakers, so I'm very thrilled to be here. So thank you very much, Blaze, for the invite. So you heard our introductions. I'll dumb it down a little bit. I'm a medical education researcher, and Deila is an instructional designer, and we came together in a collaboration over the course of 2019 to 2021 to create the Teaching LGBTQ plus Health course, which launched in March of 2021. It was a wonderful collaboration working with Stanford EdTech. You're going to hear all about that in this hour. And I'll just say this is our baby. This is something that we are very, very proud of and worked quite hard on, and we feel is distinctive in the marketplace. So I'm excited to share it with you. We have no disclosures, and my Twitter's there if you want to shoot me questions later. So here's our agenda for maybe 40 minutes, and we'll have some discussion. We're essentially going to tell you about the making of the course, and that will include the educational gaps and the resultant course goals. The content that we're going to share with you is the modules that make up the course. Then Deila is going to talk all about tech. It's going to be like going to Pixar behind the scenes. It's really exciting to see what they do at EdTech. We evaluated the program at 2 years and published it over the summer, so I'm going to share some of those results, and then we'll talk about next steps. I do want to acknowledge our course team. This is the OG. This is the folks who created the course over those 2 years. Shayna Zucker was a medical student at Tulane, is now an internal medicine resident at University of Miami. And Tim, you may know, is an MD PhD student here at Stanford. And then William Botany is the creative director for Stanford EdTech. So Shayna and Tim and I wrote the course. And it was, very boring, script. And Deila and William brought it to life and made it animated and wonderful and engaging, and in ways that I never imagined. So it was a really wonderful team, a really wonderful collaboration. And I do want to acknowledge the folks who gave us money to put on the course. I'll tell you how much it cost at the very end. You can think about that as we're going through. How much did this thing cost? We were very lucky to have a TME grant, and EdTech covered quite a bit of the cost, and then Stanford Emergency Medicine in my lab covered costs as well. All right, so let's watch the trailer. Let's Blaze, make sure you tell me if the audio is not working, but I think I pushed the right button. So let's try.
Great, we'll do.
In 2014, the Association of American Medical Colleges called for changes within medical schools to improve care for sexual and gender minorities, citing disparities in quality of care and health outcomes. But many schools and faculty remain underprepared to teach on the topic of LGBTQ+ health, leading students to report dissatisfaction and frustration. It is here that health professions educators have both an opportunity and an imperative to reduce health disparities for LGBTQ+ individuals. The mission of this online course, Teaching LGBTQ+ Health, is to improve the skills and confidence of health professions educators to teach LGBTQ+ health to students, while simultaneously enhancing their own patient interactions, thus fostering a more supportive climate for LGBTQ+ patients and students. This introductory course uses case examples to build on the empathy and teaching skills that health practitioners already have, while providing links to a library of citations, references, and downloadable resources. The authors and actors who gave their voices to these materials all come from the LGBTQ+ community, specifically the Medical Student Pride Alliance, and are direct reflections of the needs for improved LGBTQ+ patient care. Thank you for your interest, and know that your commitment to these changes would mean so much to so many.
So that serves as our intro, and it gives you a window into how animated and snazzy it is. I call it snazzy. I have to advance the slide. Here we go. Nope.
In 2014,
do it again. There we go. Okay, so that sort of sets the stage, and it addresses the faculty development gap in the trailer, and that's really the point of the course and why we created it. It's needed because clinicians across the health professions, not just in medicine, really have not received adequate, fundamental, basic training in LGBTQ+ health at most schools. And this is over the course of decades. And, it stems from a pathologization of queerness in the 1980s and 90s around the AIDS crisis. And, medicine responded appropriately to the AIDS crisis in many ways, and taught its students all about HIV. And it unfortunately, though, took all of the attention. We didn't get other LGBTQ+ health topics that reflected the full and wonderful relationships that queer people have, and their health disparities and uniqueness about them. None of that was taught to us. I was taught really one thing. It was how to identify pneumocystis pneumonia. And that was it. There was one question on my test, on every test, no matter what level of training I was at. It was always the same question. And, it was a gay man has a cough and a fever. Here's his chest x-ray. What's the correct diagnosis? And it would be pneumocystis. And then nothing else was taught to us. I mean, nothing. And I can speak for decades of clinicians across the health professions and be very confident that this was not material that was covered. So it leaves us then with this generational failure, right? So we have decades of physicians who were never taught these concepts, and therefore they can't teach these concepts to their students. And we now find ourselves in a time where gay people are very much welcomed in society compared to the 1980s. They are accessing care more frequently than they did in the 1980s, where perhaps they didn't go to the doctor as much, due to discrimination and bias. And we have medical students who want to practice, in whatever specialty, but acknowledging the unique needs of their gay patients, and they're demanding curriculum. And in many schools, there's no one to teach that curriculum. We're very lucky at Stanford to have Dr. Lana Cat, who put in a wonderful curriculum across all 4 years of the medical school. But that's unusual, and we're left with this cyclical failure, and we have to break that cycle. So there's a gap between faculty teaching expectations from the students and faculty training, and we need to find a way to mind that gap. And this course was designed really for all health professions, educators in mind. It really was to be a fundamental, basic, foundational course. Like none of this is queer health 201. It's 101. It's very basic stuff, but entirely new material to the vast majority of clinicians in the United States. If the savvy of you on the call, take the course, you may find some of it to be, very, very much basic and wonder where the rest of the content is. This was intentional. We really wanted folks to feel welcome taking the course and not overwhelmed, and walk away with new knowledge and skills that they could use in their clinical space. And my colleagues in the emergency department, I'm just going to use as an example, are very smart and kind and well-intentioned physicians who were never taught the right words to use. And at times, particularly with transgender patients in the emergency department, they trip up, and it's because they were never taught, and these basic concepts, terminology, and things is necessary. And we have a population of clinicians, using my department as an example, who are very excited to take these courses and brush up so that they can provide better care. So that's the gap, and we recognized it in 2019, and we applied for a Teaching and Mentoring Academy Innovation Grant, and we were very lucky that we were selected. And the grant kicked off what was a 2-year process to create the content that you'll see here. I do want to pause and let you access the course if you'd like. You can take a QR code picture here, or you can just take a snapshot of the screen, and then you'll have the links later. The course site is maintained by Stanford EdTech on the Meducation platform, a Stanford platform. It's free to register, but you do have to register with a password and such to access the course. All right, so the course includes 8 modules. And the first is the introduction, which you saw part of with the trailer. And then we go into LGBTQ plus vocabulary, and the terminology that we offer in the course is all research-based. So we came up with no definition on our own. We went to the literature and created definitions that drew from a number of different sources for every word that's in the glossary. And Deila and her colleagues made it come to life. So it's not just a Word document. It's got hyperlinks that you can hover over words, and you can link to a glossary that's downloadable, so you can get all of the terms that you'd like and use it in your own teaching. It's very interactive, given that it's a module about words only, but still quite interactive because of EdTech and how they brought it to life. The next module is social and behavioral determinants of LGBTQ plus health. And it's a video that separates both social determinants and then behavioral determinants. And we're going to watch a 2-minute clip from this video a little bit later. So this lays the groundwork for several of the case studies that come after it. And then this is a faculty development course. We weren't just teaching content. We're not just teaching content. The course is alive. We wanted to teach the content in parallel with brushing up on teaching skills and to illustrate where you can interject LGBTQ plus health in your daily clinical teaching. So when you're writing a test question, perhaps Derek and Michael bring their daughter Abby to the pediatrician after she sprains her ankle. Derek and Michael have nothing to do with the choices later on. It's just in the STEM, but it includes our community. It's inclusive in that way. So it's just an example of some of the teaching techniques that we review. Item writing being one, and role modeling probably being the most important for the learners. When they gave us feedback, that's the part of the course that they anchored on the most. And then we go into 3 cases, and the cases are really quite interesting. The first is Carla, and Carla is a bisexual woman, I believe in her 50s, who was a smoker at a very young age, and smoking is highest percentage of smoking in the gay communities in the bisexual community. And she smoked her whole life, and she ends up going to the doctor with hemoptysis, and she's there with her partner Patty, and they're not married. And obviously this hemoptysis is caused by lung cancer, and that's what gets revealed in the case. And now Carla is left with an end of life sort of advanced directive decision, because she's not married to Patty, and they have to work it all out. So that's part of the teaching of this case, and it illustrates substance use. It illustrates end of life care. It's it's got a couple of different things, and it was intentionally put first because oftentimes in these courses, the very first thing that you see is HIV/AIDS. It's almost always the first thing. So we wanted it to not be the first thing. We wanted to put something else there. But then it comes in the second module. This is Jesse and Jean-Pierre. We're going to watch a clip of Jesse a little bit later, so I won't steal the story just quite yet. And then lastly, there's Teddy, and she's is a non-binary patient who has had trouble getting pelvic exams because of discrimination at women's clinics and things. So the module talks about gender affirming care and how to create clinical environments that are welcoming, so that a patient like Teddy would go to your practice and engage with you. And here's an example of cartoon Dr. Michael Gisondi that was created by Stanford EdTech without me knowing it. So I do thank them for that. All right, so those are the cases. Let's look at just 2 minutes of video from the behavioral determinants, and then it links to the Jesse case, and we're going to look at that as well.
One concerning behavioral stereotype of LGBTQ plus individuals in the healthcare setting is a promiscuous gay man who acquires STIs, most specifically AIDS. This is a long-standing remnant of the 1980s and 90s that stems from societal pathologization of queerness and a lack of treatment, i.e. highly active antiretroviral therapy or HAART medications, resulting in early death of this particular patient population. This one-dimensional portrayal is damaging and restricts healthcare professionals from providing thorough and appropriate care. Now, young LGBTQ plus people are becoming sexually active in a time and social culture that is very different. There is role modeling for healthy relationships across generations and in the media. And there are methods of preventing STIs, including PrEP for HIV. There is still risk of STIs, particularly in gay men, in a higher rate than the heterosexual population. But the realities of how to prevent HIV and other STIs are profoundly different than the historical context. Thus, how we counsel patients and how we teach students to counsel patients should subsequently be different. HIV prevention will be further illustrated in one of the upcoming clinical case examples. This list is not all-inclusive. Rather, these are select determinants highlighted to preview content that will be discussed further. Pay special attention to these social and behavioral determinants of LGBTQ+ health in both your clinical practice and your teaching. Students may be unaware of the unique demographics and circumstances that affect health and health-seeking behaviors by sexual and gender minorities and necessary mitigation strategies. Finally, recognize the impact of minority stress on the well-being of the LGBTQ+ students that you teach. Representation of LGBTQ+ individuals in your teaching affirms queer students in your classroom.
All right, so that is a clip of a longer video for that social behavioral module. But I wanted to show that clip, and then we'll look at how it links to the Jesse case. Let's see, I did this wrong again.
One concerning behavioral.
Here we go.
See, Jean-Pierre has been living with HIV since before we met, and we've been afraid to try penetrative anal sex because of it. We use condoms for other things, but that anxiety is always there, and I wish it was different.
So it'll go from the script with the characters, animated characters, and then it goes to these screens. This is supposed to be a whiteboard, behind me, and it has, what I would put on a slide, for instance, and then at the bottom is the take-home message. So
you ask if Jesse knows the details of Jean-Pierre's
the
HIV status.
Jean-Pierre has had an undetectable viral load since we started dating, and he's diligent about taking heart.
You explain that, in accordance with the findings of the Partner 2 study, were Jesse and Jean-Pierre to proceed with penetrative anal sex, HIV transmission risk would be effectively no risk, with or without condoms.
My husband really does not want to give me HIV, though. It's very stressful when we're intimate.
You ask Jesse if perhaps these concerns might be assuaged by the use of PrEP.
So, I say this is basic information, it's foundational information. PrEP is probably, a 201 level topic for many physicians. The idea also that U equals U, undetectable, untransmittable, that is, hot off the press research for most, practicing physicians and new content. So, even though we consider it fundamental, it is fundamental to our community and its health. It's probably bordering on the edge of advanced topics. So we try to present it in a clinical case that is relatable. So let's see. That is it. Okay. So I wanted to point out with the Jesse animation, you get to see just how wonderful the EdTech folks bring characters to life and animate the stories in a way that's engaging. Compare that to like your usual workplace training videos that you've had to endure for years and years and years. I just got done with City training and HIPAA training back to back. It was great. They were certainly not engaging in animated and again, like Pixar, snazzy. This course, I think sets itself apart from the others in the marketplace because of that. Let's see. Nope.
See, Jean-Pierre has...
There we go. Okay, I'm going to turn it over to Deila to tell us all about the tech, which I think is probably the most interesting part of the hour. So go ahead, Deila.
Okay, thanks, Mike. All right, so our team, we are comprised of, we're very fortunate actually to be illustrators, animators, instructional designers, project managers, all in-house, which is not common, especially in education and especially in medical education. So we start off our process of working on this course and any course that we build, really digging into the learner. So I get a lot of questions whenever I tell people the title I have. I'm an instructional designer, and most people haven't heard this. They have no idea what it is. And my description for it is I'm a learner advocate. My role is to sit here and think about what does the learner need? How are they going to react? How are they best going to retain the information? So this learning design document, since we've actually kind of updated our process a little bit. And we now have a whole big binder that we do, but we spend, we like to have as much time as we can, both doing needs analysis, focus groups, really getting to know the population. And this course, in some ways, can be even more challenging, courses like this, because they represent a very diverse population of learners. And we kind of, one of the things we did do, Mike and the team and I discussed, like, who is going to be our most difficult learner? And our most difficult learner is going to be someone who is maybe inherently resistant to the topic. And we wanted to address that, to really focus everything that we present in a factual health equity lens. And so that kind of, as you can kind of see in this, is one of the things that we did. And ironically, I love all of our content. I love our animation. And the thing that I think we get the most praise for is that glossary. And it really has to do with the other thing that was evident from research prior to the course is that the barrier to people retaining and adopting or having this, or sorry, I'm phrasing this wrong. The barrier to people displaying the behavior that we are attempting to shift is confidence. They don't feel confident. And a lot of them would say, because I don't know that I'm going to do it right, I'm just not going to do it. And so that's where this came, was like, okay, well, we're going to build that confidence, help you, give you the tools as a physician, as a clinician, that you need to not feel like this is a foreign concept. Okay, so this is how the process started. And then the next step is the storyboarding. And this is, I guess you could say, where it starts to get fun, because it starts to get visual. And we spend a really focused amount of time on scripting. It's another thing that I'm personally passionate about as a with a film background, is that I don't know how many people here have taken health trainings, and the dialogue, you're like, nobody speaks this way. So we spend a lot of time really cleaning up, trying to make these scenarios feel as natural as possible, because when it's not, it's a distraction, and that's a hindrance to retention. So in here, we're looking, and then we also want accessibility is in our minds and in our planning from start to finish and through review. And that's where the visuals, we don't want those to get left behind, because we want to make sure that what's on the screen is a very clear conceptual depiction of the content that we're trying to teach. So the storyboarding is the first part of that process. And then we get a little bit more refined in our storyboards, where we start to, before I feel like we're mapping out concepts, and now we're building a story. Like Mike has said, yes, Pixar level, because our animators have gone through, I can honestly say, the program that many Pixar animators went through. Two of us, myself included, while I switched to film. One of our production lead is a San Jose State graduate, and San Jose State's very well known for their animation program. And they work very, very hard to make sure that these visuals are engaging. That's the most important thing, is that they're something somebody wants to watch. It's always important, but it was exceptionally important to us on this project that the talent that bring it to life be the talent that can relate to the content. Nothing about us without us. And there was no problem. That's another funny thing, is sometimes people will give the defense of, well, we just got to go with, who we know and who we have and well, it wasn't a problem. There are many people in a very, especially in the arts, a very diverse pool of talent. And these individuals who were voices and also content consultants, that's the best part about having members of the population that you are either teaching to or teaching about be also part of the creative process, is they give invaluable feedback about not just the accuracy of what you're building, but the quality. And then, I already jumped to that one. Okay, so here's the kind of the nitty gritty, the technical. We're building, I am an Adobe educator, and our team is an Adobe team. We use many other applications as well, but I would say that the base cornerstone of our creative work is done in Adobe applications, specifically Character Animator. This is Lauren that you see on the screen in the upper right-hand corner. So the way that it looks so realistic, or I should say more realistic than some of the kind of blocky ones that you've seen, is that this program uses AI to connect to a person. So she's actually acting some of these parts out, and then it's filling in those motions to give more natural body movement, facial expressions, that sort of thing. So character animator, Illustrator, and Photoshop, I would say, are the cornerstones of a project like this. Keeping it real, it's not cheap. It is expensive and time consuming to build artwork this way, because it's customized and we're not using stock graphics. We are building this custom. Oh, you can change it. No, that was good. That was good. So this is our tracking system that we use, F-Track, to monitor our process and our hours. And it's been amazingly helpful for us to really understand where the time and energy is going, what's the most expensive piece of these processes. And as you can see, character animation. These are the number of tasks that we have, and each task could be anywhere from an hour to 24 hours, something like that. Like, we're just tracking time against these tasks, but it took 111 separate steps in the animation process. And then, as you can see, storyboarding is not far behind. We have, it's funny, I think of this, I don't know how many people here are familiar with simulation, but there's a saying, spend 10 seconds or 10 minutes to save 10 hours or something like that. Spend 10 minutes, save an hour, 10 seconds, save 10 minutes, something like that. It's just like that in film production. Spend as much time as you can in pre-production, and you will save twice that amount of time in production. So that's why you see storyboarding being second to that. The review process is really also extremely important, especially when you're going to take in feedback from multiple stakeholders. If anyone here has ever had to review a piece of media, even a static graphic, and had to pull constructive feedback through email from multiple sources, then you know the pain that that can cause. And this system, where we send someone a video, they can play it back and then leave their feedback in time with the video, so helpful, worth its weight in gold. It's also just really easy for everyone to see each other's feedback and then build on it. So this is the system we use to review and revise, and these go out multiple times throughout the process. And then when we have somebody who maybe is just going to come in at the very end to give an overall reaction, like a focus group or part of the learner population, this is also a great way to get their feedback, because it's easy to send out. Our interactive content, for the most part, we're building out with H5P. Sometimes we do things that are a little bit more custom. In fact, in upcoming projects, we're hopefully going to do something very custom. But this one is, there are a series of stock options. What you see on the screen is a hotspot. And for learning, what we want is we don't want passive learning. We want active learning. We don't want someone just watching videos and answering questions at the end, because we know they won't retain it. I guarantee you, many of you, if I ask you what was on your HIPAA training in a month, you will not remember it. You could probably answer the question right, because let's face it, we've all seen it 50 times, but you won't remember the question. And part of that is because it's very passive. And so this allowing our learner to click around, to think, to prompt them to go from literally to touch the mouse, and then see something else come up that prompts them to do the next thing. That interaction is really what's kind of going to clinch in the retention of our information. This was just a nod to the glossary that we use, made by this company. And what we really liked about it, again, is that active learning. So when you're going through the course, the nice thing about this is it's tied to everything. So, because it's in WordPress, it's not flowing the same way in Coursera because it's built for WordPress, but we're working on that. The glossary knows where these terms show up in the other parts of the course and other text on screen, not on the video, but just on the actual, descriptions and content, and then allows you to link back to the definition. So if someone's reading a caption and maybe there's a term in there they don't remember, they can hover over it or click on it and see that definition and then continue about their way without having to exit this section of the learning that they're working on. This is a great tool. Specifically, I like to draw attention to this one because I think it has a lot of applications for medical education. And it's this concept of walking somebody through multiple prompts and then develop or spitting out a document they download and take with them. Another phrase I say, doctors love dittos. I can't tell you how often I get praise for these things that someone can print out and take to the clinic. Like, this is great. This is what I need. And part of me is like, wow, we spent $40,000 and, 1,000 hours building out this animation, but your favorite part is this printout. To each their own, and if it works, it works. But this is for the learner. So what we're doing in this one is a sexual health history, and we prompt them. Here's a thing about partners, answer it. Then they advance. Here's a question, a prompt to give an open answer about all of these 5 Ps. And then at the end, they can download what they entered into all of those and have it later for their own review. And then we can see what were people saying, because we also get that data on the back end. And then each of our, we have one question for each of our cases that also drives in whatever that key learning objective is. What was the overarching most important learning objective? And we just want to know how they're reacting in an open answer, because I don't think we get as much insight into our learners with multiple choice questions. There's always a certain factor of guessing and luck that could be factored in. Whereas this, we want to hear their words. We want to see, are they saying it? Are they picking up on those keywords? Are they applying the concept, most importantly, to their own practice? Not just the case, but how that concept plays out in what will be their future work. And I love this one too. I feel like this should be used in UME more often. It's a interactive timeline that can be used for like teaching about the dinosaurs or whatever. You can enter in all these dates and put information, and someone clicks on a date and then they get this kind of box that can pop up with video or images and more details. To me, for a patient history, that's great, because then I can zoom back and I can see, okay, here are all the different points in this patient's life that impacted health. And that kind of bird's eye view, you don't really get, even in EPIC, you don't really get that. So it's a neat way to present a case. This is just if for our team, if you ever have questions, curiosities, or a specific project that you want to pitch for us to work with you on, our consultation form is how we do that. It's go to the website, and the help page walks you through a few questions, and then we sit down and talk about your work or your questions. And these are our current metrics, but they continue. No, this is when it first started. We've had.
This was week 1. Yeah.
This was week 1. I should have logged in before this so I could get today's metrics, but we get these nice little update emails from Coursera too. So we've got this on a multi-platform setup, which I highly recommend for anyone else who is considering building educational materials. The more platforms you can get it on, it's just like social media. If you're going to post it on Instagram, you may as well put it on the rest of them, because then you're going to catch more people and you're going to take advantage of more algorithms. So as we want this to reach as many people as possible, I always joke and say your mom could take this course and get something out of it. That we want it to be something, we want to lean into the algorithm that Coursera has, the algorithm that Google has, all of those things that help kind of also push our content to someone who might be looking for it. The feedback that we get in a couple of places. We're hoping to get, that's one of the things in our future updates that we're going to be refining, is how we get learner feedback. But our CME accreditation feedback is great. And we've used a lot of that in our evaluation of the course and to help guide the next iteration.
All right. I wanted to make sure that that EdTech was featured in a discussion of this course, because the partnership really was quite wonderful. And if any of you are interested in creating educational materials, such as this, I really would encourage you to work with the folks at EdTech. They were amazing, and I like to think of myself as sort of a creative medical educator, and I realized that I'm not creative at all. They're the creative people, and I just wrote script. So I want to share some data with you. We did a formal program evaluation at the 2-year mark and published it this summer in JMIR Medical Education. We used the REAIM framework. So it's useful for MOOC, so massive open online courses. This is technically a MOOC, though we really haven't hit the dissemination numbers of a normal MOOC. But this is a nice framework for looking at all the inputs and outputs of a course. So it's not just the course evaluations, it's not just the test scores, it's all sorts of things that you see here on the screen that are important to the course and can help us gauge whether it was successful or not. And we did this purposely and very rigorously because we wanted to know, should we keep the course going? Should we add more content? And if the program evaluation came out showing that we wouldn't do those things, we would have closed the course. So we went through this process quite rigorously. So just looking at the 2-year engagement, we didn't hit massive dissemination numbers that I would hope. I didn't know what we should expect. I had no idea how many people would take the course. But you see here on the screen, more folks registered and they didn't necessarily take the course, because I think when it first launched, there were no CE credits for nurses and such. So they registered and they didn't proceed in the course. Many people take the pre-test but not the post-test because they don't need CME. The post-test is mandatory to get CME credit. But some people take the post-test over and over and over again until they get it 100% correct. So it was sort of interesting to see the behaviors there. We did migrate it to Coursera in February. Deila did a great job, and this has gotten us, more learners. Every week I get an email from Coursera telling me there's another 10 people that took the course, which is kind of exciting that it continues to grow. So looking at some of the data from this program evaluation, we are really excited that the tests that we created were representative of the learning objectives, and they resulted in the course resulted in statistically significant changes in those test questions. So the test is the pre and the post are the same. It's 10 questions. The first question is a freebie. It asks an attitude question, so you automatically get a point. So there's 9 questions really, and you have to get 8 out of the 10 to pass. And of the, how many people took this pretest? 1782. Out of the 1782, 1 person passed the pretest. 1. This includes all of the people who, are from our community doing the research, et cetera, et cetera. 1 person passed, which is really remarkable. And and this is across disciplines. It's across ranks and years in practice. Everybody failed. So the course has importance. It's addressing an educational gap. So in the post-test scores, there was a median improvement of 3 points, which moved most people into passing range. And if you do the p-value and this, that, and the other thing, it's significant. We had CME evaluations. Here you can see essentially strongly agree or agree ends up being about 90% or so as positive responses for every item that we queried. So you see them here. There's overall ratings and relevance to my practice, et cetera. We did sentiment analysis of the free text responses that Deila was describing, where you could input various notes to yourself, or you could commit to a practice change, et cetera. And, when we did the analysis, it was very positive in all of the cases that we wanted. Then we did thematic analysis of the free text responses as well. And I don't have the themes here, but from the discussion of the themes, the analysis showed that the course changed provider perspectives. And there's a lot of comments in the evaluations about how, this was enlightening, and I'm going to do something different. It supplies new teaching material, it's downloadable material, and refine clinical skills. And this sort of came across in all of the majority of the comments. All right, so costs. I should have held off on the slide. So it's $57,000. I don't know what folks were thinking, as we were describing it, but it was expensive to create. Now, part of it is creating the platform, and then the rest is the modules. And now we have the platform done, and it's ready. So it's a little bit less expensive to add content, but certainly these modules, the videos and things, with the animation and et cetera, they are costly. But it's also creating what I think is a great product in the marketplace. So just to talk about that, so most schools have no faculty development related to this topic. They certainly don't have online or asynchronous faculty development. Ours was the first course to do that. Harvard has since built a platform for a sexual and gender minority thread that goes through their preclinical years, and they did a massive faculty development push to be able to teach that course, and their content is probably more extensive than ours, but it's all just like videos. So you just watch someone talk about PowerPoints and things, and it's not interactive at all. So these are the only two faculty development courses in medicine reported in the literature. Like, there's only two, and this it makes the course very useful, right? So it's asynchronous, it's online, it's free. It could go to any faculty member at any medical school in the country. We could scale it up significantly so these medical schools don't have to create their own and recreate the wheel. So these costs are expensive, but they could affect a lot of learners if we could get our dissemination plan working. All right, so we'll close with some next steps, and I will acknowledge our new team members. So we are adding content, and these fine folks are going to be helping to write the cases and the content to the teaching points, et cetera, as we build that the new modules. I'm very grateful to TMA. They gave us another grant. We just found out. So it launched, it was awarded on October 1st. I found out, I think, on the 28th of September. So very excited. We put in for this grant specifically to create content about transgender health. And specifically, there's going to be choose your own adventure. Blaze has really got us onto this. Choose your own adventure clinical cases where you might give a hormone at this dose or that dose, and then different things unfold in the case, and that's another level of interactivity that we're planning. And then very grateful to Stanford Medicine, Technology, and Digital Solutions, who also gave us a nice pot of money to continue building course content. So together, it's just about $200,000, and we're going to be able to add a lot of content. In fact, I think we're going to essentially have a second course. There's probably going to be course 1 and course 2, and course 2 will be a little bit more advanced. So our goals for next year is, we want to build this content, and we need to write it in the next several months so that EdTech can use most of 2024 to build it. I would really like to find some experts who can help us disseminate the course more broadly. We use social media, and we did a lot of grassroots marketing. I would say to everyone who took the course, if you enjoyed it, please share it with your colleagues. But it didn't. It hasn't gotten everybody. The marketing part is not my forte. So we really haven't gotten it out. Intentionally, been much more passive. Folks finding it online. We do want to increase the Stanford engagement. So when we looked at the end users, probably about 2% came from Stanford faculty. So we certainly would like to see more faculty take the course at our own school. That might have to come from incentive programs and things, but we hope to add that soon. And then we're going to provide additional teaching cuts. So thank you for listening to this hour and engaging with us. And I'll say, to close, how can you get involved? So please take the course. I would be very grateful. Incorporate the content you learned. I promise everyone on this call will learn something. It's got a lot of content. It's very rich. Again, share with your colleagues. We are still dependent on grassroots marketing right now. And then I'm going to say at the end, contribute new course content. So this platform could be, and this is sort of what we envision, a suite of offerings, educational offerings that any Stanford educator could add to. We are building material in the ways that I described, but certainly others could build material and then have it on this platform so that we have a central educational warehouse, or suite for the LGBTQ plus health program. So, I really encourage you, if you've got the wheels turning and you think of a module that you really want to add to the course, please reach out to us. And this is the time for us to, to be picking that content. All right, so there's our emails, and that about wraps it up. So 7 minutes to answer any questions. Let me stop sharing. All right, yeah. So
we had one question.
Oh yeah. Well, Deila, real fast, just I want to say a big shout out and thank you to both of you for this talk. This was really wonderful. So a round of applause as we move into questions. And then Deila, I see you addressing the question in the chat. So go right ahead.
Just one, can the layperson take this course? Absolutely. Anybody can take the course. The only thing is you have to register with either Coursera or MedEducation. So you fill out a little form and then you have complete access to it. Another thing that didn't get mentioned is that we've also, more when we first launched it than now, but I think we would like to revisit those efforts. This course was designed to be reused in any capacity. Somebody could link out to it. Someone can even download the content and use it in their own system if they would like to. We encourage that. So for example, we've had a couple of OBGYN clinics specifically really wanting to put Teddy's case into maybe an existing course that they have, and we've walked them through, okay, here's the package to download, here's how to embed it into your content, et cetera, et cetera. And then also the biggest bumps we've seen in active participation have been when we've done this, when we've gone somewhere, presented the course, shown it to people. Doing that and having that trailer so is really helpful. So by all means, also please pass on the trailer, because that's kind of the biggest seller. When people hear online education, there's definitely a stigma. There's definitely something they think about that's not what this is. And so they see the trailer and are much more motivated to check it out.
And I just have to say I think a comment that Dr. Gisondi said earlier about, this is a one-on-one course. I watched it and got a lot out of just observing the interactions and how you both put together the content to explain it to folks. Like I got a lot out of watching those interactions, watching how you delivered the information, watching how you phrased it. So I think they're not, overselling it when they say that everybody's going to get something out of it. And I think it expands more from one-on-one because it gives really good scripting. So I highly recommend it for anybody.
Thank you.
We have 5 more minutes. So you have a great opportunity to ask these two experts who have brought, and I want to highlight technology and med ed education together, which I know is EdTech's one of your missions in a really beautiful way. So I really encourage any questions that folks have about this.
I have a question from a design perspective, because it was so refreshing to see the feel of this so much different. I'm sort of tired of seeing all the people in places where it's a white background and it looks very like Instagrammy, Pinteresty, and it was nice that the feel of it wasn't just this like white, really expensive, modern, like kind of place. And was there intentionality with that?
Definitely. One of the biggest things that we want for our learners is for them to be able to relate to the environment that we're displaying. Like this is the place that you work just as much as it is anybody else. So when we do our backgrounds and our layouts, 2 things go into mind. One, on the practical side, is we want to be able to reuse them, because that way we get the most out of the work, and we will continue to use these scenes in future content. In many cases, they're also right out of Stanford. We literally went around the hospital with cameras and then made illustrative examples of different clinic spaces. But in order for it to be relatable, I personally don't relate to somebody in a organic, like random background. I like to see them in their physical environment.
Thanks. I know it was refreshing. I enjoyed it.
It's more expensive though. I will say that
Yeah.
the reason you see white all the time or these neutral backgrounds is because they're a heck of a lot easier. And you can purchase them. It's just a green screen composite. But we consider this time well spent. And again, we'll
Yeah.
reuse it. This is with this course, we have built a brand, and hopefully you'll see that as we develop new pieces of content where, I know Mike said we're hoping, no, there will be a suite of new materials that come out that are very clearly Stanford LGBTQ health content. And you will see these backgrounds and the style used over and over again, hopefully creating a level of comfort from our learners and trust in our curriculum.
I know we only have 2 minutes left, but I had a question for you too. What was maybe an aha moment as you were putting together this content that you have now? Like, was there something that you set out with that, at the end was like totally different than you had thought? Was maybe one of a big surprise in how the content actually came together versus what you were originally thinking?
I think it really was when we started attending meetings at these individual clinics and presenting the course, that was an aha moment for sure, because it was, we've had a lot of courses that are widely applicable across the country or internationally, and we still just don't see as much of an uptick, but showing the content, walking somebody through it, that's the best way. And then that disseminates. So like we had people reaching out to us from clinics all over the country, all the way into the military. And the other thing I think, it wasn't really a aha moment, but like kind of aha, it worked, was that I think the kind of the clincher in reaching our hardest target is this very factual, this is health equity. So when we say it that way, I love this, my favorite part is the social and behavioral determinants of this course, because we're very clear about, this is about providing equitable healthcare. This is not even just specific to, this is if the same way you care for any population, you need to understand the things that affect that population and not let us tell you what those are. And saying it, just making it plain, is very effective.
Oh, Mike, you're muted, but I see you adding. Mike,
we can't hear you.
I was saying very gracious thank yous to Blaze for having us today. It was really a pleasure to be able to showcase the course.
Well, thank you both. Thank you for your work. This is really beautiful. As you pointed out, it changes the landscape of how we can educate, especially educators, faculty members, but really, I think everybody across the nation. And so I just want to say, like, thank you for doing this work. Thank you for all your commitment, time, energy, resources to go into this. I'm so excited about our next steps. So big round of applause to our speakers. Deila, Dr. Gisondi, thank you so much for your work and for being here this morning.
Thank you for having us.
And thank you all for joining this session. Have a good day.